Welcome to the Coronary Corner Podcast by SYSTOLE. Pleasure to be here to record episode 4 of our podcast. We're discussing a very exciting and timely topic, the use of CT for bifurcation PCI. I'm here with my co-host, Dr. Manos Brilakis. Manos, tell us about bifurcation PCI. Why is this a relevant, important topic, and how does CT fit into all of this?
Yeah, thanks, Yader, and welcome everyone. It's great to have everyone back on the podcast. Bifurcation PCI is something very common. About 1 in 5 PCIs that we do involves a bifurcation, sometimes even more. And there's also a lot of confusion still about how to approach them. Do we need to worry about the side branch or not, and what technique to use? And as we'll discuss, I think CT can provide some very useful insights about how to best tackle these complex, sometimes lesions.
Perfect. So, to your point, I think we've talked about previous episodes about CTO and all these complex lesions. Osteal bypass bifurcation continues to be one of the main challenges out there. I think, of course, we can tackle this from maybe the standard path that we've already talked in previous episodes. So we have somebody that was referred to the cath lab because of obstructive disease in the CT. We look at the CT, we're concerned that they may have bifurcation PCI. And first, why don't we look at the axial? So how do you think about axials as a number one step?
So bifurcations can sometimes be complex. So it's good to understand what guide we use. Use maybe 7 French guides for most procedures if you're planning to put a balloon or stent on the side branch. And what CT can help us is size the aorta, so we know what's the size of the guide. Is it a 3.5 centimeter aorta? We'll have an EBU 3.5, or is it larger, or is it smaller? So same we do for other PCIs. It can help us size the guide. If we see that the right coronary artery has the bifurcation and is an anterior takeoff, then we can use an Amplatz, an AL.75 L1 guide. So in that respect, it's very similar to any other PCI. It helps us size the guide catheters, and also, as we discuss, then understanding the likelihood of needing to go with a potential two-stent strategy can help influence the size. In general, at least 7 French for most bifurcations, where we plan to do a two-stent bifurcation technique.
I think this is just an excellent point. I can tell you as this field is, continues to grow and emerge, when we submitted one of our initial papers on the use of CT for bifurcations, one of the reviewers alluded, like, why are you talking about axis for PCI guidance? And it was clearly, you're speaking about it with a lot of confidence, but still some people don't connect how that you can do that with CT, right? And to me, you really, hammered on the right concept. That is, if you see a bifurcation, I know operators are different, but I really like the idea that if this is an LED diagonal, I don't want to go 6 French. I personally am a big fan of 6-7, slender, right guide, put 2 wires, and you're ready to go. Is that what you do?
Yeah, absolutely. And it's not only for sizing the guides, but also getting to the heart, especially if you have a patient with low EF, you're considering hemodynamic support, you can look at the iliacs, you can look at the subclavians. So if you extend from the coronary CT, it can help you decide on the need of hemodynamic support feasibility through various exercises. But for the day-to-day bread and butter, you can really go in prepared, have less surprises about what guide you're going to use. No need to try 4 or 5 guides to find the one that you're going to use in the end.
The last concept of the guide selection, because another message that we've learned through our experience, I can tell you, is that, our techs that we work with in the lab, they really, I think, appreciate when we do this sort of cases, right? Because let's think about the standard case. The standard case, maybe we go 6 French, we start with a couple of diagnostic catheters, we learn that there's one bifurcation, and then we potentially think about upsizing, and we've used a little bit more contrast and radiation. Here it's just totally different, right? We probably upfront choose the 6-7 slender, let's say if you're going radial, or 7 femoral. You upfront use that guide, and you're telling the techs, I need the 7 French, and you can almost tell them, I need 2 wires. So already think it from efficiency and equipment utilization, something that's very helpful for overall the case, but the team really appreciates, because I'm sure this happens to you. The moment you walk into the room, the team tells you, what do we need? And you can upfront tell them, and that's very transformative, I think.
Absolutely, and also it helps in deciding the diagnostic part. You don't have to do 4 views. If you're going to do imaging, for example, from the CT you're going to have a bifurcation, you're going to do imaging on both. You don't have to do 5 views on everything and spend 40, 50 cc's of contrast. You can take a couple good projections. You can even choose the angle of the projections based on the CT, and then you can do your intravascular imaging down the line and essentially save a lot of dye, contrast, guide catheters, and time.
So as you talk about angles, maybe we can shift to the next concept. So we've done the axials. We've looked at some of the overall case. Now we're maybe going to the next concept that we've discussed in previous episodes, MIP. How do you use the MIP here in this case?
I must admit, this is my favorite view because it doesn't require any processing. It's done automatically by the software and gives you an immediate 3D reconstruction of how the coronary arteries are. You know if there's any anomalous takeoff. You know if there's calcium. For me, this is a great way to look at calcium on the space and what length there is. Of course, the cross-sections are more for the thickness, but you get a very easy, just a single glance image that can give you the complexity, can get a sense for the size of the side branch. Granted, it's not very accurate for the severity of lesion, but you can really get a sense of what you're dealing with and the 3D coronary anatomy. And as you discussed right now, we can also get the angles. And for bifurcation, it's especially important, which is the angle that gives you the least foreshortening of the bifurcation. What is the best angle to place my balloons and my stents, especially in the bifurcation?
It's an excellent point, and I think people could debate: do you start with the axials? Do you start with the MIP? I know that a lot of the purists, radiologists, cardiac imagers will want to look at that raw data and start with the axials and we look at those concepts that we just discussed a minute ago. I would admit that I often tend to go to the MIP for the same reason you said. It's easy, one click, and in 1 second you know case complexity. And if it's a pretty slam dunk bifurcation, we will agree that this is not the necessary sensitivity or specificity to, that you have to do in other views, but you can clearly see, oh, look, there's an LED diagonal, or there's a, RPDA, RPL. So you can see that. So you can see the bifurcation, you can see the complexity and the calcium. So right at the upfront, you help with complexity. I don't know whether this is too provocative, but I will say that if it's a bifurcation PCI and it's in the realm of two-stent technique, I think this is something that I would already put in a more complex category that you want to do at your mother's side. Would you agree with that? Or
yeah, and you do get a sense, and most bifurcations can be done in most cath labs. But when you see that you have a significant side branch, the angulation is very unfavorable, there is significant calcium. I think we'll talk in a few minutes about what determines the risk of closing the side branch. That can help you get prepared and potentially either do an upfront two-stent strategy or have low threshold, wire the branch, and have low threshold to convert it to strategy to two stents if the provisional does not work. But maybe we take it now to your algorithm. So you look at the CT, and you see the bifurcation, and we've done the axial, select the guide catheter, we've done the MIP. Now, do you do to the MPRs to decide how you're going to approach the bifurcation, in which strategy you're going to use? What is your algorithm for approaching them?
Yeah. And as we've chatted before, I think previously, I think the easy way to remember this is not to reinvent the wheel, but it's just to use concepts that we know from intravascular imaging, such as MLDs, morphology, length, diameter, and physiology or virtual PCI. Now, I think it could be debated, and there's different ways to do this, that you could say, I want to start with the virtual monitor and physiology first, and then go to the MLD from the MPRs, or vice versa. So again, different ways to do this. In reality, how I often do a lot of these things is if there's a good quality CT and it does not involve like a prior bypass or instance, things that would not allow you to do physiology, I think starting with the 3D modelings for physiology is so practical, particularly for bifurcations, because in one click, you get a 3D model that will easily really display that bifurcation understanding. And why would I say that it's important at the upfront, in this particular case for bifurcations, to start with that virtual modeling, is because you're trying to inform yourself very rapidly. Again, we're not diagnosing a coronary disease, we're now planning the procedure. So a colleague of ours has already looked at this. It really helps you understand at the upfront very quickly, is this a potential provisional PCI or is this a two-stent technique, which you alluded to before? So if in the 3D model, it looks like it's pretty much main branch and looks like the side branch does not have a major abnormality, you're already thinking, okay, I really want to investigate that main branch. Of course, you're going to look at both, but you're already in one mindset. Whereas in the 3D model, it becomes slam dunk apparent that this is a true 1-to-1, medina score bifurcation. Then I think you are going to tackle this in a very different way. So I think at the upfront, if one can quickly understand is this a provisional versus two-stent technique, it already sets you in motion as to how you're going to tackle now the MLD and the MPRs. So let's pretend this is an LED diagonal, you open the 3D model, and let's just pretend this is a true bifurcation. I'm going to say, okay, perfect. it looks very tight on both. FFRCT is abnormal in both branches. Now we go to the MPRs. And now we're trying to address CT-based MLD, morphology, length, and diameter, with most automated softwares, whether that's your standard post-processing system or some of those others that use some AI and other clouds. You can usually target, this is the LAD, or you can just click and select, okay, I'm interested in the diagonal, and it's going to give you, as long as it has a good reconstruction and nice center lines, it's going to give you, okay, this is the multiplanar reformation for the LAD, and let's say then for the diagonal. And now how I've shifted to now do this is to try to make it as analogous to intravascular imaging as one does. So for OCT and IVUS, what do? We do an intravascular imaging pullback. So what I like to do is I like to take the length tool from some of these tools, and now I just go distal, and now I start coming back. So our brain processes in a very similar format as we do with IVUS OCT. So what are the questions? Is it calcified or not? You're trying to say, what are my landing zones on the length? And then if the CT is properly vasodilated with nitrates and whatnot, you're trying to understand the vessel size. How do you use the MPRs for this diagonal assessment, for LED diagonal bifurcation assessment?
No, very similar to what you said, but I would argue that the virtual PCI, which is taking it one step further and doing the virtual PCI in both branches, can be extremely useful here as well, because it can help you plan. You open one branch, see how the other one looks like. If it still looks suboptimal by FFRCT, they can really help you. So you still need the diameter, you still need the morphology, decide if you're going to have some calcium modification or not, but you do need to take that into account, and what is the physiology going to be afterwards.
It's a great point. These things are together, right? Sometimes I think we like to think like there's different camps, like there is an anatomy camp or a physiology camp, but increasingly as we're moving forward in this field, this is really, we're thinking about these concepts together, aligned, right? So you're saying, yes, there's functional disease in both main branch and side branch, but now how are you going to modify that plaque, and are you thinking provisional or to stent? Talking about the virtual PCI concept that you brought up, I think this is very important, right? All of us, when we were, at any stage in your career, it can still be ambiguous whether you're doing, are you doing a crush technique, mini crush, DK crush? Are you doing a clot? How are you doing? To me, a particular asset of the virtual PCI is that you resolve this before you enter the cardiac catheterization laboratory. You can pretty much take your virtual PCI planner and you can do exactly what you did. You can simulate all these techniques, right? So you can bring a stent all the way from the diagonal and park it a long stent all the way to the main branch. But the key thing is that, that is another thing that I like, is that with the virtual modeling, you're going to say, in the side branch, I need a 15 millimeter stent. In the side branch, I need a 38 millimeter stent. So you're going to get a good understanding not only of the technique, but the length of the stents that you need in those side branches, which I think it really makes it easier for planning.
Absolutely. And then also makes the procedure faster. As you said, the techs can pull them up, have them ready to go. But one component that we don't routinely have available, but it will become available very soon, and helps us decide about all this, is also the myocardial mass, which is listed on the document, but still now requires a little extra work. It's not easily available, but it's becoming more. It will be available soon universally. And that part is very useful, because if you have more than 10% of the myocardium supplied by the side branch, then you know this is a branch you cannot afford to lose. And therefore, one can plan that, hey, we have to make sure we don't lose this branch, so we have at least put a wire in if there's any concern of losing it. And then CT can help us detect the chance of the branch getting closed up. And what are the parameters you look at? I know in the angiogram we look at the stenosis, calcium. What do you look at on the CT, on the side branch, to see what is the risk of the side branch closing down?
The concepts are still the same that we just talked about, right? The presence of disease at the ostium of the side branch, particularly. So if you have significant disease, that's going to be a problem. But calcium, particularly in the main branch, I think we're learning more and more, and I think we need to see more data, but calcium at the main branch, particularly if it's contralateral to the ostium, will be an important thing. I think what we've seen anecdotally in a lot of these cases, I can tell you that I've, to some degree, have shifted my practice as I better understood the concept of calcium distribution is that if you have calcium contralateral to where the origin of the side branch is, let's pretend you don't modify that aggressively. What's going to happen is that the stent there is going to shift towards the side branch, and it's going to have a higher chance of jeopardizing that side branch. So I think calcium in the main vessel or disease in that ostium of the side branch are really key parameters. So again, it will help you understand the risk of jeopardizing that side branch. I do want to go back briefly to the point that you alluded to of myocardial mass. This is something that we're still learning. It was in the P4 trial, so it was part of the pivotal CT versus IVUS non-inferiority trial that has been conducted. It's a concept that I think we're still trying to learn how to integrate into clinical practice, but I think it has a lot of value, right? Sometimes I think subjectively we say like, oh, you just you lost a septal, but what does that mean? Is that I think we're learning that maybe some of those septals maybe have more myocardial mass than even some diagonals.
Sometimes you get surprised, as you said. You see some branches that you don't expect them to be that significant, and then clearly they're massive, 15-20% of myocardium supply. Septals, diagonals, but also on the inferior wall as well. I mean, for me, this is all helping you streamline the procedure. So instead of going in, you're going to do three IVUS runs, you're going to predilate. Before you do all this, you can plan ahead and says, look, this lesion is unlikely to work provisionally. I have a bad angulation. It's a very significant side branch. The risk of losing the side branch is very high based on all these parameters. There is actually a CT-based score. You can actually make it very more accurate that this is the likelihood of the side branch being lost, and then be prepared and go straight, for example, your DK crush or your upfront culotte, whatever is your preferred two-stent technique. This way, it goes faster, it goes smoother, less chance of losing side branches and having to struggle to get back in. It can streamline the procedure and get some of the stress related to bifurcation PCI to decrease.
Perfect, thank you, Manos. So I think just to really put together all the key concepts that we've discussed over the past few minutes. Really, I think there are three messages that I think are important. One is that even though we're talking about CT and PCI planning, it starts with access. So really, CT, if there's a bifurcation, you get the upfront, particularly if needed. You're, again, thinking about maybe you need 2 wires, maybe you need a 7 French. So remember that CT can be used for your access site selection. Number 2, again, thinking about that CT-based MLD, you're really looking at that morphology, presence of calcium in the main vessel and also on the side branch to try and understand what is your risk of potentially jeopardizing that side branch. And number 3, understanding that there are novel tools that are emerging. One of those is things like myocardial mass that helps us understand, objectively quantify the risk of that potential myocardial mass that you can lose if you jeopardize that side branch, and that can objectively inform you whether you need to protect that vessel or make a stronger effort to rescue that side branch. And also finally the issue of virtual PCI that helps you really understand now what technique you're going to do even before you enter the cath lab. So again, thank you for listening to this episode. Manos, closing comments?
Yeah, thank you so much. Like everything else, the first few times it will be kind of weird and you have some difficulty, but with practice, it can really help you make it faster, safer, and more successful.
Thank you to all for listening. If you've enjoyed this content, please do visit our website, SYSTOLE.live, and subscribe for more additional content. Thank you.